you all to optimally managing periodontitis in the GP practice. And we're very honored to have Dr. Sam Lau. And I've worked with Sam for years. He's a legend when it comes to laser dentistry. He has tons of experience in treating periodontal disease and using lasers and then incorporating that successfully into dental practice. He's been the president of the American Academy of Periodontology and the Academy of Laser Dentistry, an associate faculty member at Pankey Institute for 25 years, and professor emeritus at University of Florida College of Dentistry. And he's also developed the perio repair protocol for the Waterlase I Plus. So I asked Dr. Lau to do a 1-hour overview because I visit a lot of GPs' offices doing laser training, and GPs want to do more and more, but they also want to know what they can be successful with and what maybe will cause some challenges. So tonight, Dr. Lau is going to go over those 4 different stages of perio and the risk factors in each, and when can hygiene treat things successfully, and when can a GP, or when should we refer that out, and what do we do in each phase with the laser, and the results have been tremendous. And I've heard Dr. Lau speak many times, and you guys are in for a treat. So Dr. Lau, I'm going to go ahead and turn it over to you.
Great. Well, thank you, Nick. And for those of you on our webinar tonight, thank you for being there. This is a subject that is close to my heart. And what it really came down to was around 2008, 2009, I had already, as a graduate director of periodontics at the University of Florida, and having my own practice, I think before I was in denial. I was in denial that flap and osseous periodontal surgery just wasn't fantastic for patients. I was drinking the Kool-Aid. I didn't know that there was any other way. I had actually been exposed to the Periolase made by Millennium and the controversies around it by my colleagues that were periodontists using the Periolase for procedures called LANAP. Like the others, I was somewhat inconsiderate to the possibility that something of that nature. But the more I began to think about it, I said to myself, well, maybe it's not exactly that procedure, but maybe it's close to it. So I began to do my own brand, and also looking at pioneers in the Waterlase family, especially people like Brett Dyer and Stu Rosenberg and Larry Nuren. And they were all also creating different kinds of procedures tackling the periodontal patient. So what I want to present to you is 2 or 3 things. One, let's look at actually periodontal disease right now. No, we're not going to go back to dental school. I wouldn't bore you with that on an evening. But let's look at the current thought about the etiology of periodontal disease, because I think that will be a factor in what we're going to do with a laser. Number 2, let's just look at lasers in general. And number 3, let's take 1 and 2 and see if we can't make 3 by creating the possibility of where lasers may have something to do with periodontal patients. Let me give you, right at the very beginning, there's no such thing as a silver bullet. Believe me, we've been through what we thought were silver bullets. There's no panacea in managing periodontal patients. But what we're going to suggest is, from an adjunctive standpoint, this pretty well hits on my 3 major components of what a mission statement is for a practice. 1, provide the highest quality of care. Number 2, be happy doing it. Number 3, let's make some money. As I always do with any presentation, I start out by giving you my email. And although this will be recorded on Zoom for Fortune with Nick, if you would like this slide deck in color through Dropbox, if you email me, I will make sure that you get it. So let's take a look at where we are. First, as a disclosure, these are groups that in the past or presently I've had some relationship with, whether it be Florida Pro, Periosciences. I am a vice president by LACE, so let's just get that out right now. Phillips, Hugh Freedy, Dentsply Sirona. And so as we talk, and I mention any of these products throughout the program, you will know that in the past and some in the present that I've had these relationships. I want to show you a case. I love this case. I show it often. This is a patient in my practice. She comes from a small community called Palatka, Florida, which is about 40 miles east of Gainesville. It's a big sawmill town. Her husband owned a insurance agency. Now, what you see over on the left is her 10 years ago. And what you see over on the right is her after orthodontics in 10 years. Now, what you see on the periodontal, the Florida Pro charting is her. The red is bad, the black is good. I think all of us would agree that this is a moderate to severe periodontitis patient. And that's going to become important to us here in a moment. However, if we look at the clinical, I mean, you see very few signs of gingivitis. But when you look at the radiographs, especially the maxillary second molars, you'll notice that this is truly advanced severe periodontitis. This, as we look at staging and grading, this is definitely a stage 4. And because she has smoked in the past, we could consider this to be at least a 4B, possibly a 4C, but probably a 4B by the new AAP guidelines. Now, what brought her in was number 8, this maxillary right central. And again, if you go back and look at the radiographs, and again, if you go back and look at the charting, you will note that especially number 8 has a huge circumferential defect on the palate. And you'll notice that the ring light on my camera actually put a highlight around the fistula tract. And again, if you look at the maxillary molars, where we saw in the radiographs, you'll notice that we have got 927, 747, 985, 637. And so this is a challenge. You'll notice that there's also mobility patterns. And I can tell you a little bit about the patient. She feels significant remorse for having the orthodontics done in the first place, to the point that she wants no teeth extracted. And she is willing to do whatever it's going to take to retain her dentition. So now I want to fast forward 5 years. Now, did I grow a lot of bone? No. Did I stabilize? Yes. Especially number 8. And then if I show you what she looks like 5 years later, yes, there's a black triangle between 8 and 9, bone, gingiva tries to find bone. But if you look at her pocket depths now, and being realistic, we still have problems between 2 and 3. We still have problems between 14 and 15. But we periodontists, and hopefully by the end of this program, you in general practice, we can keep single-rooted teeth. We keep them all day. It's those molars that become the problem. So you might ask, why did this turn out, I think, pretty well? And what did it take? Well, let me give you a little story. 1, We looked at the occlusion, we did occlusal assessment, we did occlusal adjustment, and we put her in a maxillary night guard. 2, we ran her through 4 quadrants of scaling and root planing with local anesthesia by a dental hygienist that knows root anatomy. 3, we didn't put her on floss. We put her on very big proxy brushes, dipped in medicaments. 4, we had her back in 8 weeks later to do a phase 1 evaluation. And anything that was 4 or greater, we introduced her into possibly what one might call laser-assisted periodontal therapy. It doesn't matter, but we utilized our laser to literally do adjunctive to get the result that you get. And so if you see a side by side, this is her 5 years and a fairly successful case. But again, I can tell you, as we always talk about, I got a little brush fire going on 14 on the straight buckle where there's a fur cup. So let's just get out of the gate and talk about some mythology. 1, periodontal disease is not caused by bacteria. It is incited by the bacteria, but it's caused by the host. It doesn't get worse over time. It's time to rethink how we do oral hygiene. It's time to rethink about scraping on roots and sharpening curettes. It's time to realize that when you see a red halo around someone else's zirconium, it's not an allergy. But it's also time to be realistic and realize that we just can't do 212, 212, 212, 212. My suggestion to you is if you're going to manage periodontics in the practice, don't just look at the roots. Don't just look at the calculus. Start looking at the reaction of the soft tissue to the local factors, in addition to what's on the roots. And you're going to see me stress this over and over and over again. Calculus does not cause periodontal disease. The body's reaction to the calculus through inflammatory mediators that eventually calculus doesn't destroy bone. The inflammatory mediators that are incited by the calculus destroy bone. So you're going to see this evening that we're not going to use our laser necessarily as an antimicrobial device. We're going to use our laser in addition to a certain degree antimicrobial, but as an anti-inflammatory device. So whether it be incipient inflammation, whether it be significant inflammation with loss of attachment, whether it even be as far down as the possibility of affecting the periodontal ligament, all of this is about what you see on the left, no inflammation, and what you see on the right, a significant inflammation. The little dots that you see there are not bacteria. Those little dots that you see there are hyperactive neutrophils, lymphocytes, and plasma cells. So let me just get ahead of myself here a little bit. Wouldn't you want to do curettage? Wouldn't you want to consider about degranulation? And you probably can see my cursor, my little arrow. Wouldn't you want somehow to go in with something? I don't care. Blade doesn't matter to me. Blowtorch, and go in and remove this segment right in here. And we're going to find that that is what I have put my emphasis on, at least for the last 10 years. And it's called degranulation. So I'm not going to take us back to dental school, but I am going to suggest that many times when I am consulting with someone over a case, one of the problems that I have is I don't have good radiographs. The probing is not correct. One's not looking at attached gingiva, and mobility is so crucial to what we do in occlusion. So it's just time honored that I must suggest that they have to have radiographs to where I can see the bone. I've got to have good probing good probing, not overangulated. And this is where one of my conflict of interest comes in. I helped create something called VoiceWorks. And I did it so that your hygienist could do a complete periodontal exam with no keyboard, no foot switch, and be able to create a chart like what you see here, completely with her voice or his voice. And when we look at that, so now let's you and I, remember I said there'll be three things. We're going to sort of look at where is perio now. We're going to look at generically about lasers, and then we're going to merge the two to get a synergy. Dentistry is way behind our medical brothers and sisters when it comes to laser. There's not a dermatologist out there that doesn't have a laser. There's not a plastic surgeon out there that does not have a laser. And I would suggest to you that if you wanted cataracts removed and they give you a blade versus laser, you might want to consider the ophthalmologist that has a laser. And the reason we love lasers is that lasers are, to a certain degree, about as natural as you can get, because it's light. Someone will say to me, well, Sam, how do I explain to a patient what a laser is? It's light. How does it work? It works by primarily vaporization. And I don't want to make this complicated because we're going to talk about different wavelengths. But really, I always think about four targets. Red is blood, brown is melanin, pigment, white happens to be hydroxylapatite, and water is on the blue. But when you think about perio, here's where I think some of the issues come in. We think perio is only soft tissue because that's what we see. But perio is not just soft tissue. Perio is also roots and bone. So why did I choose an all-tissue laser? Well, primarily because it can work on soft tissue and work on hard tissue. And I'm going to show you what that means. So when one looks at the targets that we just went through, those four things, if you get the right wavelength, it will not go through the target, it will not scatter, it will not reflect off, it will be absorbed. And that's basically what you want. And so I'm going to start to put this into two categories. I'm going to talk about diodes, which, by the way, 35 to 40% of all dentists have. They're soft tissue lasers. And then I'm going to go over to all tissue lasers and primarily spend a little bit of time with erbiums. Now, appreciate, especially the diode, if you're not careful, you can get thermal effect, and we call that carbonization. So anything that's greater than 200 degrees centigrade is carbonization, and we don't want that. We want to be able to ablate tissue, but not really have a irreversible thermal effect. So now let's put it into these two together. Soft tissue lasers are phenomenal in perio. You know, they decontaminate, they deepithelialize, they degranulate, they denature proteins. One can do wonderful gingivectomies with them. And if you put it in a pocket, you can inhibit the epithelium from going in. So if you know anything about, guided bone regeneration, guided tissue regeneration, any GBR, GTR, whatever, you know we're trying to keep the epithelium out. Because when the epithelium goes in, then that's when we have an invagination and we don't get attachment. If the epithelium goes in, that's how we lose bone grafts in GBR. That's why we put membranes in there, by the way. Hard tissue lasers. Hard tissue lasers work on cementum, calculus, dentin. They remove bone. In a moment, we'll show you they may biostimulate bone. But the beautiful thing about periodontal surgery is hemostasis is one of the primary cardinal positives of this laser. And with hemostasis, it creates something called visualization. Now, there's a new kid on the block. It is called photobiomodulation, biostimulation. We are in the infancy of this right now, pioneers. We do know that we're getting incredible wound healing acceleration with lasers, but we kind of don't know why. And we're hoping more and more research will occur, but we think possibly that lasers are igniting the mitochondria in the cells to produce more ATPs. So here's an example of some diodes, but most of them are fairly small. They've got a fairly good footprint to put on your bracket table. They're pin lasers. Most of them have foot switches. And these are and they're, relatively speaking, they're low cost. So we're going to see basically, if I use that diode laser, what can I accomplish in periodontics? So these diodes, they cut, they coagulate. They're very good in the spectrum that we talked about, the red and the pigment. They're outstanding for hemostasis. In certain situations, especially non-surgical, you might even be able to get away with topical. Surgical precision is there. And again, as I mentioned about the photobiomodulation, for whatever reason, it does appear that we're getting excellent postoperative patient-related outcomes. So I kind of like flowcharts. To me, I appreciate graphics. So if there ever was, and if you have lasers and you're talking about non-surgical and you want to screenshot this, this is the slide. Because this puts everything in perspective. My gross debridement, what my hygienist does at the charting, and you have 3 categories for the hygienist. It's gingivitis, I'm going to do prophylaxis, and possibly do laser bacteria reduction. It's moderate to severe inflammation. This is the 4346 code. I'm going to do laser bacteria reduction. But if I have scaling and root planing to do, then I ratchet it up. And although I may still do LBR, what I need to be doing is curettage. So for chronic periodontal disease, we're going to break it down, like Nick had mentioned, into categories and what we do with each category. So we look at about 47% of all Americans over the age of 35 have at least early periodontitis and need something beyond a prophylaxis. So again, I'm very methodical. Here is our periodontal diagnosis early, and I can tell you, we can manage this with a dental hygienist utilizing a laser, especially with curettage. Moderate periodontitis, now we're getting a little shaky here. And here it's going to take an all-tissue laser. And again, as we talk about severe periodontal disease, this absolutely cannot be done with a diode laser. It takes more. So let me just break it down to you. I'm speaking to an audience now of general practitioners. Early periodontitis, 15 to 20%. Definitely done by a hygienist. Moderate periodontitis, 25%. Where I want to go with you is you, as a general practitioner, managing moderate periodontitis. You may reach a point that it is not a good return on the investment for you to manage severe periodontitis, and that may be something you want to refer to a periodontist. But this is all about suppressing the epithelium so that the PDL can grow back, generating the cementum and generating the bone. So let's talk about those diodes. That would be swim lane 1. That would be the early periodontitis. And in that, we've got 2 procedures. There's only 8 states in the country that absolutely do not allow a dental hygienist to use a laser. Only 8. The other 42 do. And so with laser bacteria reduction, you're only going 1 to 2 millimeters into the pocket. And therefore, your tip is uninitiated. But we have added that if you put hydrogen peroxide, 3% hydrogen peroxide from Walgreens, into the sulcus, the laser will initiate the hydrogen peroxide and will literally cause hydrolysis and have a major effect on the bacteria. And we call that laser bacteria reduction. This is an example of a diode. This is the Epic Hygiene made by Biolase, and the presets are all there for LBR. But I'm a big fan of curettage. And in curettage, you're going to use an initiated tip. In curettage, you're going to go all the way down to the bottom of the pocket. In some circles, we call that laser-assisted periodontal therapy. And again, if you have something like the Epic Hygiene, it's wonderful because you already have presets, initiated tip, but this time you're going to the bottom of the pocket and you are doing curettage of that entire sulcular lining. And then you're going in with your ultrasonics, especially those that are thin in diameter, sharp on the sides, and you're able now to have incredible access. So where you see hand instrumentation, scaling, and rubber cup, in my mind, personally, that's antiquation. Let's move you into the next generation of what we're trying to do. And that next generation is using the laser to open up the sulcus, remove the epithelium, come back, not with curettes that you see in the center, but with ultrasonics, and following that with what we call guided biofilm therapy. And this guided biofilm therapy is phenomenal. It uses erythritol powder. It can work on orthobrackets, periodontal pockets, pits and fissures, ceramic restorations, implants, exposed cementum. This whole thing behind guided biofilm therapy, it is the present and future of how we manage biofilms, and we call it GPT. And here between 5 and 6, we insert our laser for this. And again, this is a airflow device by EMS. And it has on one side, on the left, it has your piezo. On the other side, it has your erythritol powder. It warms the water, and I would ask that you truly look at EMS airflow. And if you email me, I will have websites for all of this. So insert design with the ultrasonic. See, I'm stressing not so much the laser, but using the ultrasonic as part of the debridement, after you've gained access, almost like troughing. So for gross debridement, we use low to medium power settings, triple bin inserts. Gingival debridement, we use, again, low to medium power settings, thin design. But remember, if you recall, I really pushed that the result that we got from the very beginning of the very first case when we started was not just the laser. It was the hygienist, it was the occlusion, it was the oral hygiene. And then we came in with the laser. Seriously take a look at today's ultrasonics, whether it be magnetic-restrictive, that is Cavitron, or whether it be piezos, which are my favorites now. The bottom line is we got to get into that sulcus. We've got to get in that sulcus and not only do antimicrobial, but also anti-inflammatory. So let's begin to move towards some kind of closing here. Let's start looking now at the next juncture, and that would be for our patients that need you or need a periodontist. And we want pocket reduction, don't we? We basically don't want threes. To a certain degree, as far as sulcus, we'd love to have ones, but you better be ready to live with 3s and 4s and 5s because it's all about access. So this is for our hygienists and possibly you, if you're in a state that doesn't allow hygienists to do it. This is done with a diode, and this is either laser bacteria reduction or curettage. But look at these. Pocket depth 45 millimeters. Local factors is calculus, edematous, single-rooted, horizontal bone loss. And with this, if you see over on the left, what we were able to do, what you see over on the right, and that was with a dental hygienist using ultrasonics and a diode laser. Now look at this though. Notice that especially on 10, but definitely between 14 and 15, we still have residual pocket depths. What does that mean to us? We're now going in with an all tissue laser. We are, not the hygienist, to turn this around. And when we do that, these are unretouched films. When we do that, my friends, we can gain attachment and we can grow bone. We can grow bone. I always say, let's borrow from the East. If you remove the stimulus, the body will repair itself. So this is your case, or a periodontist. Pocket depths that are 5 millimeters or greater, not a lot of calculus, but gingivous fibrotic, multi-rooted, angular bone loss. This is your case. And although the endo probably has something to do with this, we are saving this tooth. Where we had 9s and 7s on the back end, now we have 2s. We had 10s on the back end, now we have 3s. But it's still part of basic periodontal care. And I know I get a little frustrated when there's some speakers speaking on laser that again make this thing look like it's magic dust. It's not. So what we are doing now is that we are raising a small mini flap for using laser. We're not doing closed flat procedures on these kinds of cases. We need to see the bone. We need to see the root. And we need to add bone where we need to have that. So although there's procedures out there that are trademarked, I still believe when you need to add bone, you need to add bone. And when you need to see the root, you need to see the root. So I'm not a fan of basically closed flap. No matter what laser company is promoting it. Now, in an aesthetic area, I may be open to something, and this is an aesthetic area. This is an 8 millimeter pocket. We're going to go through the steps called repair perio, deepithelialization, et cetera, et cetera. We're going to use a special tip that BioLace has called a radial firing tip. The reason I like it is that the energy, 90% of the energy, 85% of the energy is going out, which is what I want. I don't want it going straight down into the PDL. Another case, we're going to do closed. Here, it's a 11 millimeter pocket. I'm not going to reflect a flap here and get a dark triangle, but I'm going through all these steps. And 3 years later, guess what? I end up with from an 11 to a 4. So with all of this, it's procedural. And we always utilize our ultrasonics. In surgery, you would be surprised. Most of the time, if I were to time it, most of my time in doing a perio repair, moderate to severe case, is actually the ultrasonic instrumentation. But therefore, we also follow up. And that follow-up does include things that you might be surprised at. And one of those is pre and post, we have our patients on oral probiotics. And take a look at oral probiotics. These things may be the future of oral hygiene. You can take one tablet, which is freeze-dried organisms, put it on your tongue, suck on it, and it basically runs out the periodontal pathogens and those organisms, especially strep, mutans, and lactobacillus, for caries. So there are many of them out there. I kind of favor something called Probiora. That's what you see in the center. And because its organisms mimic the kinds of organisms that will inhibit other organisms. However, I do want to suggest to you that when we do these procedures, you want to be careful with chlorhexidine. We have known for 20 years that chlorhexidine induces fibroblast death. Oh, it's incredible as an antimicrobial. But what you pay for the antimicrobial, you're going to lose on the fibroblasts. So chlorhexidine applied to surgical site prior to wound closure can have serious toxic effects on gingival fibroblasts and negatively affects wound healing. So personally, I have removed chlorhexidine completely from our repertoire. So what have we added? Well, we've looked for gels that we can use postoperatively. Gels that are not only antimicrobial, but gels that are also anti-inflammatory. And one of those gels is Periosciences AO Preventage Gel. Here's our patient, but I'd ask you to take a look between the lateral and the central. And this is 21 days later. Nothing has changed. There has not been any more debridement. The patient still has their same oral hygiene. In fact, there's still biofilm at day 21. And let's look at her lower. Day 0 and 21 days later, just using this gel, putting a drop on the tongue in the morning, and especially a drop on the night before bed, and seeing the difference. And this is Periosciences. So this gel is used for us with post-periodontal surgery. This is aesthetics. Our patient comes in, she doesn't like the lateral on the left. We do some aesthetic perio, put her on the gel, and that is her 5 days later. 5 days later. So it's a combination, and this is called Periosciences gel. I love the AO Preventage gel, and again, if you email me, I'll send you the link to this. So let's put some dollars with this and be very realistic. Unfortunately, non-surgical perio with a laser, that being the laser bacterial reduction, that being the laser-assisted curettage, there are no codes. You have to put in the primary code you're using and add this adjunctively, and generally it's going to be copay. There's no other way. There are no laser codes. In fact, there's not even a curettage code anymore. That was to be the D4220. So how do we get around this? Well, we're doing the 4341 and the 4342, but we're adding a fee. So I can tell you what those fees are. For LBR, we generally run about $50 for a mouth for laser bacterial reduction. But if we're doing curettage, which is going to take more time, we're doing $50 a quadrant in addition to the SRP, and that being copay. Now, friends, I will tell you, if you demonstrate the value of adding the laser to the repertoire, they will pay you for this. And even if they didn't pay you, it would still be incredibly positive in you getting the result that you desire. Because there is something about the curettage opening up the sulcus so the hygienist can go in and do the instrumentation. However, let's now talk about you. And you doing these periodontal laser procedures with opening of a little mini flap. Here, if you open up a mini flap and you do see the bone, and you do some decortication of the bone, then your case is open to the 4260 codes, which is osteosurgery, 4 or more teeth. That's the 4260, or the 61, 1 to 3 teeth. Now, I'm going to be quite frank with you. If you use a laser and you do not reflect the flap, and you do not work on the bone, you shouldn't be using these codes, because in the descriptor, it says flap reflection and osteosurgery. I just want to make sure that we're all clear on this, because there's folks out there, closed laser periodontal procedures, going through the sulcus, not reflecting a flap, not working on the bone, and unfortunately putting in 4260 codes. And I just don't want to see you be subjected to an audit from you know who. So I hope that explains about laser coding. This is incredible for your practice. So what we have here is what I kind of call, and other people have it too, but I like it. I like my term, which is like total perio solution. What does that mean? That means my early periodontitis is managed by my hygienist with ultrasonics and laser. That means that the middle swim lane, moderate periodontitis, is managed by me with my laser, but reflecting of a small flap and osseous grafting. That means if I have time and interest, that I might want to go into the third swim lane, which is only 10% of perio, which is severe periodontitis, which probably is always going to require some kind of bone grafting, and that is done with laser. So I hope that I've been able to create the synergy of the 1 + 1 = 3. And again, this is my email. If you email me, I'll be more than happy to answer your questions, but also send you this presentation in color. So Nick, I'm going to turn it back over to you.
Thank you, Dr. Lau. At this point, I want to open it up to questions. So if anybody has any questions, what I'd like you to do is on your screen, there's a mute button and it has a line through it because you're all muted right now. You just need to tap on that. So if anybody has any questions, I'm going to open that up right now.
And they can be provocative. This is the time. I will tell you what I'm thinking, and we can move forward. Don't be bashful. By the way, if you do use osseous grafting with 4260, you're probably aware that you can use an additional code for the osseous grafting. It's not like we're trying to get as much money out of the patient as we can. That's not what this is about. But we do know one thing. When you have angular defects, osseous grafting does make a difference, a big difference in the result. So.
Sam, did you want to talk about any of the risk factors, within each of the 4 groups or buckets of perio, where maybe diabetic or smokers or things like that are
Sure.
definite ones where you think, hey, I could have some success here, or maybe we're not so much here, because I think that's valuable too.
Sure. And the best way to do that is I'm going to do it through staging and grading. Staging is 1 through 4, like we discussed. Staging 1 is early periodontitis. Stage 2 is basically, we start moving into early to moderate, then we have moderate, and then we have severe. The grading, as I talked about, was ABC. So Nick, relative to your question is this. Patients who are smokers, no. Patients who have nicotine in their body. We just found this out in the last 5 or 6 years. I don't care whether they patch it, they snort it, it doesn't matter. Nicotine is nicotine. And so with nicotine, what you're going to get is a compromised inflammatory system. And you're just not going to get the result that you'd hope for. Now, if they're a smoker, I can promise you're not going to get the result that you had hoped for, because it will impede, as many of you know, the vascularity, and you will not get the wound healing. From a diabetic standpoint, most studies demonstrate that now I'm not talking about type 1, that's a whole different animal, but type 2 under control should not be a real factor here in your result. Now, type 2 and shaky control, which unfortunately most are, that could have an effect again on wound healing. So we look at risk factors as this. Genetics is number one. But in alignment with that, nicotine next, diabetes next, and occlusion. You'd be shocked at how many of my patients are in maxillary night guards that are especially severe periodontitis or aggressive periodontal disease. So don't get frustrated by this. Sometimes if you don't get the result, go back, look at the medical history, go back and look at the environmental concerns such as nicotine, and you're probably going to find where the issue was. Now, I'm gonna also speak to one thing. We forget that this is a pocket. The distance between my thumb and this finger is a pocket. But that pocket is made up of two things. It's made up of, if this was the CEJ, it's made up of attachment loss. And it's also made up of pseudopocketing. So where we get confused is that when we do laser periodontal procedures, we may have an effect on this, but if we don't do a gingivectomy and remove the gingiva coronal to the CEJ, what makes one think that you're going to decrease the pocket? And this is the number one issue. When someone calls me up and says, I'm just not getting the results, I'm going to say, did you remove the pseudopocket? Because if you don't remove the pseudopocket, there's no way that gingiva is going to attach to enamel. Gingiva attaches to cementum or dentin. So I hope that clarifies. You would be shocked at how much gingivectomy I do in the posterior, especially on the palate. When I see that gingiva halfway up that enamel, or on the lingual around the 30-31 area, and I see that gingiva halfway up the enamel, there's nothing I can do to decrease that pocket unless I at least remove some of that gingiva, which we do, whether it be a laser or my favorite is gingivectomy knives. The bottom line is this: you don't want pockets. And there are three reasons you don't want pockets. One, access, but not by the patient, but by your hygienist. Number two, we know that gram-negative anaerobes, pathogens, cannot live in shallow pockets. They like deep because it's anaerobic. Number three, we know that as long as you maintain that inflammation, there will be memory cells. And until you remove those memory cells via some kind of degranulation, you're going to have an issue. But I will add one more part, which makes this even more intriguing. We know that the number one reason a patient loses an implant, a dental implant, fails, unfortunately, is cases where the history, where the patient lost their teeth from periodontal disease. Isn't that amazing? The fact that they have no pockets, they're edentulous, yet they still contain, floating through there, these hyperactive neutrophils, lymphocytes, and plasma cells. So this whole thing is about inflammation and risk.
Okay. Go ahead. I think someone unmuted and had a question on your iPhone. Any other questions for Dr. Lau?
Email me.
Yeah, Fred asks, what do you recommend for follow-up education on the same topic?
You mean follow-up? Oh, your education.
Yeah,
Not
Freddie.
patient, not patient education, but your education, right? That's right. I think that's what one means.
Yes.
Perfect. Unfortunately, like everything else, you get a textbook, it's outdated. If you're looking at lasers, it depends upon what laser you have. Most all lasers, right, Nick, have some kind of education program, including what Nick does. So if it's about laser perio education, it's going back to the vendor or utilizing Nick as a resource, or email me and I can find you some resources for this. Especially, if you look at BioLace, they have advanced courses for general practitioners. I'm doing one this weekend, actually, in Foothills. Hands-on courses using laser. Fatana does the same. Millennium does the same. But if you email me generically, I can probably put you in touch with some courses, especially if they're generic.
Thank you, Dr. Lau. I have in my office, I have a soft tissue diode laser from Clinician's Choice, which I stopped using a while ago because then I got a Solea laser, so I use that more.
Right.
And I would like to learn more about like how the technique would be for some of those procedures you mentioned, using like the Solea laser, for example, and even the diode laser as well.
The diode, I've got you covered. I will send you, I created it, but I have a guidebook on how to use the diode laser for non-surgical perio. The issue with Solea is that the tip is probably sometimes not easy to use in a pocket due to size. I'll just be really frank with you. It's wonderful for crown lengthening, for gingivectomy, for prenectomy, for everything else. But I will tell you, it is difficult to get a Solea CO2 tip in a sulcus and know where it's going to end. We just don't want the energy going in and doing any more damage to the PDL. But I have you covered on the diode, and you can do a great deal with that diode with the guidebook that I have for you.
Awesome. Thank you so much, Dr. Lau.
You're welcome.
Any other questions? Just looking at everybody here. All right. Well, I appreciate everybody taking the time out of your busy schedules. And again, Dr. Lau, thank you for taking the time to help educate on periodontal disease and how to optimally manage it. And again, I will be posting this on the website, and we will have that up hopefully in a week or so. So that'll be posted for you guys if you want to go back and look at it. Thanks again for you all.
Perfect. Have a good evening. Thank you.
Okay. Thanks.